Morning. Welcome to Grand Rounds. My name is Suresh, and I'm with the Divisions of Emergency Medicine and Health Informatics. It's my pleasure to introduce our speaker, Dr. Sandy Chung, the 2023 President of the American Academy of Pediatrics. Dr. Chung received her medical degree from the University of Virginia and completed her pediatric residency at the Innova Murphy Children's Hospital in Virginia. Dr. Chung has held over 30 state and national leadership positions, including AAP Virginia Chapter President and founder and medical director of the Virginia Mental Health Access Program. She is the CEO of Trusted Doctors, a pediatric practice of over 180 clinicians in Virginia, Washington, D.C., and Maryland, and serves as medical director of informatics at Children's National Hospital's Pediatric Health Network. Her passionate advocacy for child health and pediatricians has delivered major advancements in healthcare equity, mental health, appropriate payment, physician well-being, and optimal child health policies. I had the opportunity to work alongside Dr. Chung in the Executive Committee for the Council on Clinical Information Technology for the AAP, and I'm grateful for her contribution towards EHR burden reduction. She's the recipient of multiple awards, including the March of Dimes Lifetime Heroing Award, recognizing a lifetime of community volunteerism, the Clarence A. Holland Award for providing outstanding contributions to the community and demonstrating leadership in the field of political advocacy, and the Virginia Chapter Child Advocate Award for standing up to the rights, values, and recognition of Virginia's children. As an avid educator of the next generation of pediatricians, her publications include articles on telemedicine, virtual learning, and health information technology. She has appeared in numerous media outlets, including the Washington Post, Wall Street Journal, NPR, Washington Business Journal, Virginia Business Magazine, Contemporary Pediatrics, and AAP News. In her role as the president of AAP, which is the largest professional organization worldwide for pediatricians, she has testified in front of legislative bodies at the federal level. Dr. Chung is a proud mother of 4 amazing children who, in her words, teach her something new every day. I now turn it over to Dr. Sandy Chung for her talk on protecting children's mental health and restoring our future. On behalf of our department, welcome, Dr. Chung.
Good morning, everyone, and thank you so much, Suresh, for such a kind welcome. Thank you all for joining me so early in the morning. I appreciate that so much and appreciate your attention. Today, I'm going to be talking about protecting children's health and restoring our future. To begin with, I don't have anything to disclose other than how much I appreciate you and how much I appreciate what you do. So the AAP every year sets strategic priorities. And so I just wanted to review what those are for 2023. 3 of them actually are continuations from work from previous years. And then we have 1 new one. So healthy mental and emotional development is 1. COVID recovery and disaster COVID recovery and disaster readiness, equity, diversity, and inclusion. And then our new one is safety and well-being in the pediatric profession. Today, I'm primarily going to talk about the first one, but we're going to touch on some of the others. So to begin with, let's talk about the impact of the pandemic on children. We know it's multifaceted. The isolation and social mitigation factors that we had to do in order to limit the spread of the disease resulted in economic, social, financial impact among families. Access to healthcare was an issue. When we were in isolation, families either would not or could not or should not be able to go out and seek care. And that disruption resulted in so many different things that we're only now just starting to understand what happened. We also know, sadly, that many children lost their caregivers. So as of May, the number of children who lost their primary caregivers was over 200,000. And if you add in secondary caregivers to that, then it goes over 250,000 children. And unfortunately, it disproportionately impacted children of color as well. And we know that the consequences of orphanhood and the consequences of losing that primary or secondary caregiver is incredibly traumatic. And as pediatricians, that's going to be our role to manage that and the consequences and to help children through what this processing, and then also trying to figure out how do we help their new caregivers, whoever may be caring for them now, help them reach optimal health. Services were interrupted for children with special healthcare needs. And as we all know, children with special healthcare needs need ongoing, continuous access to medical care. And that disruption was problematic again. And also, we also know that communities of color, again, were disproportionately impacted. Suicide, as we all know, is sadly the second leading cause of death for young people ages 10 to 24 years of age. In that very first part of the pandemic, when we were having isolation and shutdowns, we know that children did not get sick as often as they normally would with viruses and such because they were at home. So in our emergency rooms, we weren't seeing as many patients, perhaps, at least not children. But we do know that the children who did show up, more of them were showing up with mental health emergencies. I was talking to a pediatric emergency room physician, and he had, and I'm sure you saw this in your centers as well, children who were just boarding for days and days waiting for an inpatient psychiatric bed. He was telling me this story about a 7-year-old young man who that morning his mother, a few days prior, his mother woke up and the 7-year-old was standing over her with a knife, and the 7-year-old stabbed his mother repeatedly. Now, luckily, the mother survived, but certainly the 7-year-old needs some help. The 7-year-old stayed in the emergency room for almost 2 weeks waiting for an inpatient bed because it's hard enough to find an inpatient psychiatric bed for an adolescent, much less a 7-year-old. Suicidality is not, has not been something new, of course, and the increase also is not new. This graph, as you can see, is from 2009 to 2019, so before the pandemic. So even before the pandemic, we were experiencing a mental health crisis that only was worsened by the pandemic. In the year 2020, over 6,000 children or young people committed suicide. And, you know, anywhere in the world when an airplane crashes, it makes the news. When one airplane crashes in the world, it makes the news. If you were to take the 6,000 young people and put them on an airplane, this is the number of airplanes that would equate to just in 2020. So over 10 airplanes crashing of young people, and it unfortunately did not make the news as it really should. And so bringing attention to this and finding interventions is really critical moving forward. In fact, if you look at the leading causes of death after suicide, the medical causes, and add up the next 20, the number of young people who die by suicide outnumbers that number. So what are we doing? So AAP, along with multiple stakeholders and other national organizations, collaborated to create this document, the Blueprint for Youth Suicide Prevention. If you've not seen this, I highly recommend downloading and taking a look at it or interacting with it online. There are many concrete steps here in this document that really tell us, what do we need to do? You know, what's the path forward? How do we intervene and prevent suicide from happening? And as pediatricians, we are uniquely positioned to do this work. And so there's information in there about what to do if you're a health system, if you're in a practice, if you're in a school setting, all of those. So again, highly recommend taking a look at that if you haven't already. You all may be familiar that 2 years ago in the fall, AAP, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association, we all jointly declared a national emergency in child and adolescent mental health. And then last fall, we renewed that declaration because there was still more work to be done. This certainly got headlines, but the most important part of doing this was that it opened the path for advocacy and brought attention to a serious topic. And with that public awareness comes change. I sincerely hope that in 2023 in the fall, we're not renewing this one more time. AAP has an initiative called Uprising Healthy Children. This is particularly focused on improving youth mental health. And we do this with multiple stakeholders across the country. Again, many national organizations, medical societies, behavioral health entities, youth advocates, family advocates, schools. And so again, bringing together multiple people to work on this important topic is very much a focus of the Academy. We formed a new council, the Council on Healthy Mental and Emotional Development. If you're not familiar, AAP is comprised of sections, councils, committees, and chapters. And so the council is a unique type of entity where members can become members, and then also they can generate policy. And so we felt very strongly as a board and as a leadership at AAP that we had lots of work happening in mental health in multiple domains, but we needed a place where we could bring them all together. And so that's what the purpose of this council is. It's been formed, it's being led by Dr. Marianne Earls in North Carolina. And there's an opportunity for members to join that should be coming shortly, sometime this year. So keep an eye out on your emails and on your AAP news announcements for an opportunity to join. And of course, we want to support the pediatric medical home. I am a general pediatrician in practice, and we know that, you know, in primary care, at least, it's super exciting to be able to see, you know, the child that you saw as a newborn on day one grow up and become that teenager, and ultimately to become that young adult. And then as they grow up, they may ultimately end up bringing their own children to you. To me, that's a sign of when it's time to retire, but, you know, but it's just such a joy to be able to work with families and to see children for over their lifespan as young adults, until they're young adults. And so the pediatric medical home is this opportunity for us to engage and help parents and caregivers with their children as they grow, but also it's an opportunity to intervene early. And that's really one of the best parts of pediatrics, I think, is the way that we're able to work and interact with children when they're little, so that we know when we help make a positive change, that has a lifetime of improved outcomes for that individual. But what instead of, you know, we talk about how to make children more resilient, but what if instead of relying on children to be more resilient, we instead create a world that's less traumatic? Online is a thing now, right? The children that are under 10 years of age now don't have any idea what it's like to not have the internet, of course, but they also don't know what it's like to not be able to talk to the air and have something happen, you know, to just be able to say something and music starts playing, or the weather is given to you, or you can just drop in and call your grandparents or your friends. And so this is very unique, obviously. And so as we move forward in technology, and as there's new technology, like you all may have heard of ChatTPT and the artificial intelligence things that are happening, and which is really quite transformative in the world of technology and will change how we interact with our world. It's really important that as this all happens, so that we're protecting children and understanding the consequences of these things and what kinds of guardrails need to be in place. For those of you who aren't familiar with ChatGPT, hopefully you've at least heard of it, but if you haven't, you know, you may want to try playing with it and seeing. It's really quite amazing what it can do. I'll just tell you a quick story of there's some physicians who have been playing with it, of course, many physicians. But one doctor put in information on a patient, and he used our nomenclature and wrote, you know, like it was an adult doctor, and put in 39 YOs, like year old, F, you know, for female, and then S/P for status post, and then put in all the details of that woman's symptoms and asked for a differential diagnosis. And ChatGPT came up with a perfect differential diagnosis. Then asked it for the actual diagnosis, and it did a wonderful job of actually finding the right diagnosis. Then he asked the AI for references as to how it got to that diagnosis, and it provided a whole list of references. However, when the physician went to go look up the references, they actually did not exist. They were completely made up. And because what the AI does is it looks for patterns, and so it just went out and looked up, what do medical references look like? And then it just emulated that. So it made up a journal name, it made up article names, it made up author names, made up page numbers, and so it did the entire citation so that it was formatted correctly, but it wasn't real. So as we go through and watch the evolution of AI and what it can do, there are going to be some amazing things it can do. Maybe one day it'll help us write our chart notes, because if you can teach a scribe how to write a chart note, you can teach an AI. So there are things that it can certainly do well. But as we think about how do we protect children, I think it's important for AAP and all of us to be thinking about what needs to be done. Social media currently is being spotlighted, and so we have all heard of some of the challenges behind social media and also the programming and algorithms behind social media that make it so that basically it's addictive, and it's designed so that you continuously engage. There are benefits to social media, certainly, especially through the pandemic when children are isolated. They were able to reach out to peers. They were still able to interact socially. Children who are marginalized are able to find like-minded individuals. So there are lots of benefits. And in fact, when studies ask children, or adolescents, who are they connecting with on social media, 90% of them respond that they're connecting to their friends who they see in real life. And this is just a way to stay connected when they're not together. But there are, of course, costs as well. And so cyberbullying is a concern. The longevity of what's posted online is, of course, a concern. And having that unhealthy social comparison is of concern. It is unreasonable to ask a teenager to stop using a device when they're engaged in social media. And the reason why I say that is the algorithms and the people who are programming social media are intentionally designing it against human psychology so that we will engage, or with human psychology, actually, so that we will continuously engage. And adolescents who, as we know, haven't fully formed their executive function and their frontal lobes aren't completely developed, to ask them just to stop is not reasonable, because these algorithms are designed to keep them there. AAP is very much involved in federal legislation now that hopefully it will pass. It's bipartisan and bicameral. And so hopefully we're going to see some rules and regulations around how social media works going forward. AAP was fortunate to receive a $10 million grant from SAMHSA, and the area of research around social media and impact on children's mental health is still very new and sparse. And so AAP is focused on improving that so that we know what works and what doesn't work, and what's dangerous and what's safe. If your families are asking, what can we do? Certainly AAP has family resources, so on healthychildren.org, but also online we have media plans or family media plans, so you can certainly direct your families there for assistance. Advocacy is a large part of what AAP does. I wanted to show a few things that we've been working on. We have formed a coalition with multi-stakeholders across the country so that we can all work together on ways to improve mental health and mental health funding. 988 hopefully is something you've all heard about. So 988 is like 911 for mental health. I asked a state medical director of a 988 line what was the youngest age that they've received a phone call for, and it was actually for a 5-year-old. So parents called the child's parents called 988 asking for assistance with the behavioral issue. The other thing that was interesting is the same state medical director said to me, we had to come up with an algorithm or a script for our call center folks, because they wanted to know, what should we do if someone calls us but doesn't say anything? So they had individuals who were calling and not talking. And so they had to teach their call center staff to say, I'm glad you called. I know you don't feel like talking right now. but I'm here for you, and I'll stay with you until you feel like talking. And one can only imagine that before 988, those same individuals may not have had anybody that they could have called in that time of crisis, and how powerful that is to have something like 988 where now someone can call for help no matter where they are. Advocacy, again, is very much a part of what AAP does. I did have the opportunity to testify before Congress on several pieces of legislation related to mental health. One of them supported the pediatric mental health care access programs. So TIPS is similar to what I'm talking about. TIPS is fantastic. They don't have HRSA funding because they have other sources of funding, which is wonderful. Here you can see a map of states where there are programs funded by HRSA, and again, TIPS is exactly what these programs are, where it's a child and adolescent psychiatry consult line, training, there may be care navigation resources, and again, Pennsylvania just doesn't have isn't in blue because you don't have a HRSA grant, but you certainly have a program. I founded the one in Virginia, the Virginia Mental Health Access Program, which I'll touch on a little bit later. So Congress can do things, by the way. So they did some wonderful pieces of legislation at the end of last year, including authorizing home visit, reauthorizing and refunding, doubling the funding, in fact, for home visiting programs. And wonderfully, starting January of 2024, they approved or they required that states now have to continuously enroll children in Medicaid for at least 12 months. And as we know, having insurance certainly doesn't mean you have access, but it's the first step towards that. I did want to point out that they did remove a certification requirement or a waiver requirement if you want to be able to prescribe buprenorphine for opioid addiction or substance use disorder. So removing that barrier is wonderful. I did want to also point out one thing that's less positive, but you need to know. They also passed a requirement that upon renewing your DEA license, so every prescriber who has a DEA license, the next time you renew it, you will have to participate or have had participated in 1 8-hour training on opioid use or substance use. AAP is quite aware of this, and so there's a lot that we're doing to find and create courses that are appropriate for pediatrics. There are double the number of pediatricians in Congress now. We have 2. So it's super exciting. Representative Caraveo and Representative Schreier represent us in Congress, and what a way to make change. So excited that they're there. I wanted to touch briefly on the changing healthcare landscape. Post-pandemic, there are lots of things happening. You know, there are lots of new things happening. There are lots of innovations that we need to be considering. And I think each one, we're not going to go into each of these, but I think understanding that after the pandemic, we're not going back to the way things were. You know, that's not a thing, but we do need to move forward in the future. And what are some of the things that we need to be considering when we look at that? So this is from the U.S. Census in 2021, and I want to point out some differences here. So on the left, you can see the breakdown of race and ethnicity for young people, so under age 18, children and adolescents. And on the right is the population above 60 years of age. So strikingly, you can see that for children, 49% would classify themselves as being white, and the other half, or more than half now, would classify themselves as not white. Yet on the other side, when you look at those over age 60, it tells a very different story. So where almost 3/4 of the population is white. Those who are making laws and regulations in our country tend to be those on the right. And so are we creating laws and rules and regulations that are appropriate for the population of adults that is coming? And I think as pediatricians, you know, the patients our patients are on the left. And so we see first what's happening in our communities and what's happening in our country as far as changes. And it's important that we stay at the forefront of keeping that highlighted, so that as new laws are created, that they will be welcoming and supportive of the next generation. This is my nephew. He's cute, I know. He is half Caucasian, half Chinese. My brother is his father. And then here he is with one of my kids. My husband is also of Chinese descent. So, and one can imagine that as they grow up, that my nephew might receive some privileges and assumptions because his skin is lighter colored and his hair is lighter colored, yet they share the same 50% genetics. So how can we ensure that as we move forward that they are equally going to be successful? Of course, there's personality involved too. So not worried about my son. He's going to be just fine. And here are my kids with some of our family friends. And other than my kids, all the other children are half Asian. And so as we think about the forms and the things that we're asking people, you know, what are they going to check on the boxes that we're asking people to check, you know? And as we're creating classifications based on race, what is going to happen for this next generation, which tends to be multiracial, and in the generation after that, which is going to be similar. And so eliminating race-based medicine is certainly an area that we've been very focused on at AAP, and continuing to implement that as we review our policies and our teaching materials going forward. Certainly keeping that in mind and really working on that intentionally is important. You can't list your iPhone as your primary care physician. Dr. Google is real, and maybe Dr. ChatTPT now. There are so many things happening in healthcare. I'm just going to go ahead and forward through all of these. But, you know, telemedicine was new, but it's not anymore. And so the pandemic certainly changed that. I'd been doing telemedicine for probably 15 years. And, you know, that was when I first started, it was new and novel, but now we all pretty much know how to do it. And then labs at home, you know, when I first put this slide together, it was a very unusual sort of future-like concept, doing labs at home. Yet all of us probably have a COVID test at home now. And so it won't be long before we all have strep tests and flu tests and all of that at home as well. And that's already happened. In fact, we had a mom call our practice before the pandemic to say that her child's strep test was positive and could we call in antibiotics? And we said no. but I think going forward, we may need to think about, you know, how are we going to manage that? Care at home certainly is becoming more and more popular, and to the point where even in adult medicine, there's something called hospital at home, where adults are being discharged home and almost like step-down ICUs or step-down units, where the medical equipment is delivered to a person's home and the staff is there, and the physicians come in as needed to round at the person's home. So interesting models coming forward. House calls, concierge care. Uber does house visits. I don't know if you knew that. In some cities, they'll deliver flu shots to your home. So really interesting. Of course, Amazon now is doing all sorts of interesting things as they've started Amazon Clinic online. So the next time you're on Amazon, you might want to take a peek and just see what they're doing in your communities. And then insurance is changing. And so we're all looking at the healthcare costs and trying to figure out, is there a better way to do this? Smooth seas do not make skillful sailors, so as we have been through rough times, we've learned a lot, and learning a lot, I think, and being innovative and being really creative through the pandemic. And with that comes innovation. And so as we continue to move forward, we'll see what innovations stay and stick with us. Slight change of topic here. Medicaid is something we all need to be focused on very critically right now. In August of 2022, we hit a new milestone where 55% of children in this country are covered by Medicaid or CHIP. That means over half of the children in our country are covered by Medicaid or CHIP, but also means that they're at or near poverty. Now, one of the reasons why this happened, though, is over the pandemic, states were not allowed to disenroll children from Medicaid or CHIP, and actually anybody's, including the adults. So Medicaid rosters, as you can imagine, have grown considerably. So this number is probably going to go down a little bit, but maybe not completely. Hopefully you've heard of the unwinding by now. It's starting in about 2 weeks here, actually less than 2 weeks now, actually a week. And what is this? So what has happened is Congress at the end of last year unlinked this from the public health emergency and said, no, states, now you can start unenrolling people or disenrolling people in Medicaid who no longer qualify for Medicaid. So every state is actually required to go through their entire roster of Medicaid and CHIP enrollees and see if they still qualify. And if they don't, they can take them off. Now, there's some guide rails around this. They have to do multiple attempts. They have to try to help the families find new care. For example, if they make more money now and they no longer qualify for Medicaid, they might qualify for CHIP. Or if they don't qualify for CHIP, perhaps they can buy private health insurance on the state exchange, but they have to buy that. So the really important part that we all play in this is that when you have a patient who has Medicaid come through your doors, or if you just have them on your roster of patients, you should let them know this is happening, because chances are they probably don't know it's happening. In fact, they may or may not even know that they're on Medicaid or CHIP, because it probably doesn't say Medicaid or CHIP on their cards. It might say Aetna or Blue Cross Blue Shield or United, because if you're managed care managing your Medicaid, that's what the cards are going to say. So notifying them primarily that they need to make sure that their information, their address and their phone number is up to date at the Medicaid insurance company. And if they are contacted by Medicaid, that they read the letter or they answer the phone, because that's what they're doing. They're calling and emailing and writing letters to individuals who are currently under Medicaid and CHIP to let them know that either they still qualify or that they don't qualify, or that they need further information to determine if they qualify. And if they don't answer, then they can actually just be terminated from Medicaid. There are millions and millions and millions of children and families that will be affected by this. So, really important that we all try to work on this. Now, I do want to let you know that it's not a cliff. It's not like April 1st, this all happens simultaneously and it occurs. It actually will happen over 14 months. And so there's a rolling period where people are going to be notified. So we still have time to notify our families and to make sure that their information is up to date at Medicaid. Access to mental health is also really important. So these are my kids. This is when they're a bit younger. The little man on the right, Ryan, he is cute and adorable, but he also has high functioning autism. And so certainly as a parent, I understand fully what it's like to try to find care and having difficulty doing so. The PLACES study is a longitudinal study that the AAP does, where we ask pediatricians over their career course, different questions, and most of them are mid-career at this point. And we ask them, how hard is it for you to find a child and adolescent psychiatrist for your patients? And the green, which normally is good, is very difficult, and blue is moderately difficult, yellow is somewhat difficult, and only that tiny sliver of the orange is not at all difficult. So it's certainly an issue, and this is across subspecialty and primary care. Here are some quotes from the folks who answered the survey, but primarily the message is that, especially for Medicaid, it's hard to find people who accept Medicaid, and so many of these families and children need help. As I mentioned, I started the mental health access program, again, the equivalent to TIPS in Virginia. And this has been a great way to at least expand access for for care, but it does rely on primary care. So it's training primary care providers to see more and do more with mental health issues. And then there's a phone line available if we have questions, and we can reach out and speak to a consulting child psychiatrist or a psychologist in VMAP. And then if a family needs help and ongoing care, which they all do, there's care navigation resources to help the families find a therapist or find a support group or a psychiatrist in the community. One of the challenges, though, is that now that we're doing this work, it's much harder and it takes much longer. And it's very hard in primary care for this to be a sustainable model. And when I started practicing, it was really, most of my day or half of my day was acute care visits, otitis media, strep throat, et cetera. And then the other half would be well visits. Well, now it's half mental health visits and mixed in with the well visits and a little bit on the acute care side. The visits are very different, though, right? So with otitis media, maybe that's a quick visit or strep throat, perhaps. But with mental health, none of them are quick visits. And so when you're RVU based or you just have a volume of patients you need to see, engaging in mental health visits all day actually just doesn't even become sustainable. And why is that? Well, funding is a part of that. As was mentioned, I run a large group. I have a business background to me, so I have a good, deep understanding of the financing of child health and pediatrics. And so you can see here in the United States, we spend about 5 to 7% of our revenue or our GDP on in healthcare. Of the healthcare pie, 5 to 7% spent on primary care. In other industrialized countries, they spend 10 to 15%. So the undervaluation of primary care, but if you were to take a similar pie and break and draw out pediatrics, we would be such a tiny sliver of that 5 to 7%. And as we all know, paying for pediatrics is an investment. That when we do it right, when we do our jobs, then we can actually change the outcome of the adults, right? And so as our kids grow up to become healthier adults, we are actually making the greatest impact on healthcare. Having that discussion and that argument has been something that's always been a challenge for us, because how do you show that something did not happen? How do you show that obesity did not occur, or cardiovascular disease did not occur? And so we're working now at AAP with working on some analysis to really show that. The healthcare team has changed as well. So it used to be that maybe it was a physician or a nurse practitioner and a nurse, and then maybe a front desk staff person. But this is now the healthcare team, and our payment system is not designed to pay for this or support this. Value-based care is also something that has been touted as a solution to the rising healthcare costs, but they're not designed, the programs currently that we have are not designed for pediatrics. They were designed originally for Medicare, and so they are designed for adults. So for pediatrics, we need to be focusing on the fact that we have other factors that make taking care of children and keeping children healthy. It needs to be involved, the social determinants of health piece, the medical complexity, the fact that we also have to deal with the parental and caregiver complexities, behavioral health, all of those things. So much work to be done, and AAP's focused on that. I want to just talk briefly about the last, but definitely not the least important, priority that was added this year for AAP, and that's the safety and well-being of the profession. This is a sign that is at my family dentist. So if you're grouchy, irritable, or just plain mean, there'll be a $10 charge for putting up with you. Several of my colleagues are in private practice who think that this might be a great revenue generator. But truly and seriously, the safety and well-being piece is such an issue that has come to the forefront like never before. In child health, we're not used to being targets, and we're not used to being, having our issues be controversial, but that certainly has happened, especially with gender-affirming care. And so, the dangers that this has brought forward with bomb threats and such to children's hospitals, irate individuals, social media, cyberbullying, all of that's happening. So the AAP and the Children's Hospital Association and AMA wrote to the Department of Justice a letter saying, you know, this isn't okay and we need to be protected, and people who do this need to be investigated and prosecuted because this is not okay to do. And luckily they have taken that and have been doing exactly that. The U.S. Surgeon General also has published a framework on well-being in the workplace, and I think this is a great framework. If you're in an institution in a space of leadership, or run a practice, or have any area where you have an influence on an organization, I would recommend reading this. It's not a very long read, and it's a really great framework to think about how do we keep people healthy and safe. There are things we can do as organizations. Treating wellness as a metric, you know, when we look at central line infections in the patient safety framework, we measure it, right, at our institutions, and we are held accountable for that. So well-being as a metric is one way to ensure that something happens here. And there are tools to be used, the measurement tools for this, like the Maslach burnout inventory. I think it's important to really frame physician and healthcare worker well-being as a patient safety issue, and only with that will we make movement. I did want to talk a little bit about rejecting the hero model. You know, through the pandemic, we were called heroes, and that was meant to be, you know, really thinking about how to support us, and people were so grateful for us. But the hero model is a challenging one, because if you think about a hero, you know, think about Superman, for example. Heroes do this, you know, if you think about, do they do it in teams or do they do it by alone? Well, Superman does it alone, you know, so heroes do it alone. And that's not how healthcare is delivered. We're not alone. We do this in teams, and there's multiple people working together. And so the hero model is a challenge because it puts expectations on us that are not necessarily helpful or real. The blame culture and eliminating the blame culture mindset is also important. You know, as we're trained in healthcare, sometimes who's at fault becomes the goal, and that actually is quite detrimental to all of our well-being. In my office, I can hear sometimes a provider, when a patient isn't given enough time or scheduled in the wrong spot, saying, you know, who scheduled this patient this way? And then the staff around that provider will run up to the front desk and say, who scheduled the patient that way? You know, and that is not a safe space to be in. One of the areas that I was listening to a speaker, and what he said was, we talk a lot about changing organizational culture. And when you're talking about changing organizational culture, it sounds really huge and very amorphous and daunting. But truly, when you're thinking about your workplace culture, right, so where you work every day, your workplace culture is actually set by the person who's right above you. So think about that for a minute. Your workplace culture, the way you experience work every day, that culture is actually set by the person right above you. Now, all of us in healthcare are leading teams. So you may have a nurse or an MA working with you or under you in that sort of hierarchical view. You have front desk staff, right? So that means you are actually setting the organizational culture for those individuals. So you yourself. And so I urge each of us and challenge each of us to think about that and say, if we're trying to improve workplace well-being, then we actually, each of us, have the power to make change and to improve the workplace for those who are working for us. Peer support is also really important. We know that in early childhood that having a safe, stable, nurturing relationship is key. And when that happens, then we have positive influences of things like oxytocin and parts of our brain that get activated because of that safe, stable, nurturing relationship. The same thing can happen in adults, you know, so that power of being with peers and spending time socializing, we're social individuals, can be incredibly powerful towards establishing well-being. So making sure that wherever you are, there's an opportunity just to talk and just to talk about what you're going to do this weekend. How are your families? What's going on? You know, what's hard, what's easy. You know, all of those things are really important to engaging in improving safety and well-being within our healthcare system. We're givers. You know, pediatricians are amazing. We love to help other people. We help families. We help our patients. We help our own families. We help our own friends. You may be in organizations where you're helping. So we give all the time, you know, and we're really good at that. And so it's not that that's not a problem, like at all. But the expectation that we can be immersed in suffering and loss daily and not be touched by it is as unrealistic as expecting to be able to walk through water and not get wet. And what this, you know, if you think about the amount of mental health work that we're doing now, the global pandemic that just happened, we have been giving for a very long time. And understanding that by doing this, we're giving a lot of ourselves, but we're also experiencing things. The compassion fatigue, hopefully some of you have heard of this, but really it's primarily, you know, originally it was related to nursing and maybe caring for a sick loved one at home or something. But really we've been taking care of people a long time, all of us. And to be tired and to experience fatigue is quite reasonable. It's not the same as burnout, right? Burnout is different. Burnout is, you know, I don't like my EMR, you know, or I'm writing notes at night, or I don't like not being able to take a break, you know, my days, I'm seeing too many patients each day. You know, that's burnout, and you can treat burnout sometimes just by taking a break and going on vacation and stepping away from work for a bit. Compassion fatigue or vicarious trauma is different. It's a little bit more along the lines of PTSD, and I think understanding that this has happened to us and that some of us may be suffering from this and recognizing it if you are, and seeking help. You know, I think expecting someone to recover from PTSD alone is unreasonable. Hopefully you also agree with that. And so expecting someone necessarily to recover from compassion fatigue or vicarious trauma by themselves is also not reasonable. So, you know, seeking help is okay to do. There are multiple symptoms of compassion fatigue. Here's a few of them. There's multifaceted. So there's cognitive, emotional, behavioral, physical manifestations. So you may be just, you may be feeling angry or guilty or have trouble sleeping. You're experiencing muscle aches and pains that you didn't have before. Maybe you're getting sicker more frequently. These are all symptoms of compassion fatigue. Apathy is one I wanted to point out. So if you give COVID vaccines, for example, and if you see a family and you don't talk about COVID vaccines with them anymore because you know the answer, that's a form of apathy. And so maybe you're suffering from compassion fatigue. So part of the solution is a systems change, right? So it's not all us. We need to work on the healthcare system. We need to work on organizational culture. But what are some things we can do for ourselves? And these are hopefully not new to you, but if so, you know, these can be very helpful. Gratitude is one, and so Duke researchers found that when you practice gratitude, you know, some people write down what they're grateful for or put it in their phones. It actually works even better if you tell the person that you're grateful for, and that actually brings you more positivity, and the benefit of gratitude is even greater when you tell the person verbally that you're grateful for them. Saying three good things, you know, what are 3 good things that happened today, and saying today will be a good day. You know, I don't know if you all know about the cognitive triangle. I'm just going to talk about this briefly. So in the cognitive triangle, the idea is this, that your thoughts lead to your behaviors that lead to your feelings that then lead to your thoughts. An example that I use with my patients is that, you know, if you have a friend and your friend suddenly stops talking to you. So if you think that your friend is mad at you, then you get upset. And then maybe the next time you see your friend, you might ignore them back. But if your friend's not talking to you and instead you think about it as, oh, maybe they're just really busy, then you're just kind of disappointed that they didn't talk to you. And the next time you see your friend, you'll say hi and see if they have time to chat with you. Or maybe you might think your friend has something wrong going on in their lives. And then now you're worried about your friend. And the next time you see your friend, you may in fact reach out to them ahead of time and say, you know, what's going on? Are you okay? Right? So in the same scenario where your friend's not talking to you, the way you think about it will impact how you feel and how you behave. And another example that I like to help talk people through is, think about an elephant. So if you all could just indulge me for a moment and just think about an elephant and picture that elephant. Maybe it's a big elephant or a little elephant, and, is it eating or walking around? Think about where it is, where it's located. So if you have that visualization now of that elephant, so stop thinking about the elephant. So stop thinking about the elephant. Really stop thinking about the elephant. Well, how about instead, you might still be thinking about that elephant. So maybe instead, let's think about a chicken. So if everyone could visualize a chicken, might be a rooster, might be a hen, whatever your preference, So where's the chicken? Maybe there's some baby chicks. Maybe they're walking around, figure out where is this chicken? What's it doing? Where is it? All of those things. The chances are, if you're thinking about that chicken now, you're not thinking about that elephant. And so if you're having a thought right now in your life where things are hard, or you keep thinking about the same thing over and over again, telling yourself to just stop thinking about it, stop thinking about that, why am I still thinking about that, actually doesn't work. Right? You can't just say stop thinking about it. You have to replace it with a different thought. So if you're trying to change how you're feeling, then think changing your thoughts, and not just changing it by saying stop, but by replacing it with a different thought is really important. And that's the premise behind CBT, or cognitive behavioral therapy. Very quickly, I wanted to share this, expecting the unexpected. So this is actually my car. So this happened in 2018. This is a 2018 Toyota Sienna. And so, yes, what happened? So this is at a lake near my house, and we were out fishing for the day. We have a little boat. It wasn't a big boat, but it's big enough to need a trailer. So I backed up onto the boat ramp so that we could load the boat up onto the trailer. And we had loaded the boat up, and I got out to check on it. And my husband said, he was with me, and he said, let's unload the boat a little bit first. So you can see the back of the minivan is open. So we were loading up the boat. I had left the engine running, so I decided I wanted to turn it off while we were doing this. So I went back up to the front of the the car, and reached in, opened the door and reached in. It's a push button start, so I didn't need to get in. So I reached in and just pushed the button. And when I pushed that button and turned the engine off, the car started to roll down the hill. Okay. And so what do you do when your car goes into the lake? I didn't know. So we called 911. So the EMS shows up, fire trucks show up, the police show up, everyone's there. This is at a park, so there's lots of people walking around. I'm sure I'm on Instagram somewhere. And so it turns out, we're all standing at the edge of the lake looking at my car. And it turns out you need a special tow truck to get a car out of a lake. Who knew? So we had to call this tow truck, or the police called them, and we had to wait for it. So it was about 45 minutes to wait for this tow truck. So, I was standing there and I saw the EMS folks. I'm in healthcare. So, I said to them, hey, we're okay. You can go. You don't need to stay. And the EMS gentleman, he was like, oh, well, we just want to see what happens. So they stayed. And so everyone stayed and watched. And so eventually the tow truck came and pulled the van out of the water and the trailer. And we had been fishing that day and we hadn't caught a single fish. And remember, the back of this car is open. So when we pulled the van out of the water, it was full of fish. It was great. It's a very expensive way to fish, though. I don't recommend it. So at that moment, my original thought was kind of, wow, what's happening? I was in shock. I kind of stood there feeling kind of stupid. And I just couldn't move. I didn't know what was going on. So later, when I was able to process, I had a couple alternate thoughts. It's a good thing nobody was hurt. My kids weren't in the car. My husband had been standing behind the car. He wasn't there at the time when it happened, thankfully. Cars are just things, and good thing I have insurance. So vicarious resilience is a topic I'd love to introduce to you as well. So if you aren't familiar with it. So vicarious trauma, we talked about compassion fatigue, moral injury, vicarious trauma, all of those things. And so vicarious resilience is also a thing. So the wonderful thing in pediatrics is that children recover often, right? And children are amazing. We've all taken care of kids in the ICU or who've been very, very ill, who a few days later look amazing. They're playing, they're smiling, they're recovering, and it's just an incredible experience. And one of the joys of pediatrics is how resilient children are. And it feels amazing, being able to take care of kids and see them get better is just the most wonderful, wonderful experience. I think understanding that we can experience resilience vicariously through our patients is important to understand too. And remembering why we do what we do. I love being in my office where when I watch people go into exam rooms down the hall, you could be having the worst day as a pediatrician, right? We could be 20 notes behind, we haven't had anything to drink today. We didn't get to eat our lunch, all of the things. Our families may be having something going on or something going on at home, but we are incredible actors. Well, what do we do when we open that exam room door, right? We walk in, we're like, hey, how are you? Oh, she's so cute. So we are so good at that. We're so good at changing our thoughts and our feelings and our behaviors. And that is something that we're incredibly skilled at. So I would say, why don't we do that all the time? Why don't we do that to ourselves? When we go through your day and you have 18 patients and you have that one patient who showed up late, who was a challenge, whatever the issue was, where that visit didn't go well, instead of focusing on that one visit, why don't you instead perhaps think about the 17 that went really well, where everybody was grateful and they were happy to see you and the kids were fun and things went well and your notes were done, all of that. Focus on the good things that happened in your day, and it too can change how you feel. I wanted to bring 3 concepts to you this year. So reframing, reimagining, and rejuvenating. Reframing is important. How do we reframe it from what's going on, from divisiveness to differences of opinion? How do you reframe your day or what's happening around you so that it can feel more positive and be more positive? Reimagining in this changing healthcare landscape, we need to reimagine how we deliver care and how we deliver the best care for our kids. And rejuvenating and reclaiming that joy that we also deserve. So thank you so much for your attention. Thank you for everything that you all do for children and families in your communities. I'm so grateful to have some time to chat with you all this morning. Thank you.